Good afternoon, friends. We're going to start the HOYA scientific session now, and we've got a fantastic lineup of speakers here. And chairing along with me is Dr. Ramurthy, who doesn't require any introduction, and Partha Biswas and TTR hopefully will be joining us. We have a galaxy of panelists. Dr. Rajendra Prasad on to my left, and Anurag, and Dr. Anaga Herur, all top people, and they have been using all the HOYA products on a regular basis. So we'll go on to the first speaker.
Hello.
Dr. Mahipal Sachdev. Where is Mahipal? Welcome, Dr. Namrata. Oh. For Mahipal, always the laptop comes first and the speaker comes later. Hi, Namrata. Welcome, Dr. Namrata. Been doing a wonderful job as a secretary, and thanks for the wonderful conference, Namrata. It's really fantastic.
Always welcome. The venue has done half of the job.
Yeah, I know that, I know. And also Dr. Rohit Om Prakash from Amritsar, a great innovator, surgeon, and he is also a panelist. Where is Sugas? Sugas Haldipukur is there? Please come over. Sugas from Bombay. Somebody told me he's there. Why don't you go to the second speaker then? Dr. Ramurthy is here ready. What do you say? Yeah.
You can go to the second speaker.
Yeah, we go to the second speaker. What do you say, Namrata?
Yeah, sure.
Okay. You can call the second speaker, Dr. Ramurthy, Director of Eye Foundation, and he's going to talk to us on astigmatism and toric IOLs. While we wait for Mahipal, I think Ramurthy can deliver his talk. So, I think many of us have been using this Vivinex toric, and quickly, what's your experience on that? RP, you have any experience on Vivinex toric while Ramurthy is starting?
Yeah, definitely, because when we are looking for the toric IOLs, we want something which IOL gives you an accurate result, and at the same time, which takes up its stable fixation. That is the most important part, and then which doesn't produce any kind of capsular opacification. So all these qualities are there in Vivinex toric, and we, as a clinical practitioner, have seen the results of Vivinex toric excellent in terms of its accuracy, in terms of its stability, and in terms of its clarity, and it gives a clear vision. So all these factors, the positive factors, are there with the Vivinex toric.
Yeah. Ramurthy, are you ready?
Yeah.
Thanks.
Thank you, chairpersons. Thank you, Mohan, and thank you, HOYA, for putting together this lunch symposium. I'm going to just give you an overview of astigmatism, toric and intraocular lenses, and the other speakers will be going into the specifics of this particular lens. At the time of cataract surgery, it's found that almost 2/3 or 66% of our patients have a corneal astigmatism of more than 1 diopter or more. And almost 20% have 1.5 diopters or more, and 8% of the patients have more than 2 diopters of corneal astigmatism. So this chart here shows the prevalence of corneal astigmatism. You may have doubts, you may have reservations about using multifocal intraocular lenses, but as far as toric intraocular lenses are concerned, that is something that each and every cataract surgeon has to take up in his practice and employ them judiciously for the benefit of his patients. That's simply because when you put in a monofocal intraocular lens, significant studies have shown that almost 58% of eyes which receive a monofocal intraocular lens have a residual postoperative astigmatism of 1 diopter or more. So all these 60% patients who should have ideally received a toric intraocular lens. And as far as deterioration of the quality and quantity of vision is concerned, the astigmatism remnant has an even more deleterious impact than a spherical residual error. Uncorrected astigmatism causes a loss of visual acuity of more than 1.5 lines per diopter at high contrast. And when you have 60% of the patients left behind with a diopter or more of astigmatism, obviously that are not results that are acceptable in the present day world. Towards this end, one of the options that is available to us is the HOYA toric intraocular lens. I have significant experience with this lens and find them to be extremely user-friendly with very happy patients. It has an anterior aspheric design with the toric design on the posterior surface. The toric markings are also posteriorly placed. Most importantly, it has a textured rough haptic surface as well as the edges are also textured, because of which there are certain inbuilt advantages. It also has a square posterior optic edge, because of which there is an inherent ability to prevent posterior capsular opacification. It's available from the T2 to T9 model, that is from 1 diopter to 6 diopters. And as far as correction at the refractive plane is concerned, at the corneal plane is concerned, is right from about 0.75 diopters to up to about 4 diopters of astigmatism. So almost the entire gamut of the normal kind of astigmatism that we come across can be dealt with by this intraocular lens. I did mention about the textured rough optic edge and the haptics also. Because of the textured optic edge, the tendency for total internal reflection is significantly reduced, because of which the dysphotopsia, the negative dysphotopsia especially, is reduced quite significantly. The haptics are also externally textured, as you can see over here, which gives rough contact with the fornice of the capsule, because of which the tendency for the rotation of these lenses is significantly less. Another aspect we have all experienced is when the optics and the haptic tend to stick together, and when you have this rough surface, the tendency for the optic and the haptic to stick together is also significantly less, so that the forceful separation of them is really not necessary. Again, this is the only preloaded toric intraocular lens that is available in the market today, and that's a significant advantage. It goes in through a sub 2 millimeter incision. I usually use a 2.2 to 2.4 millimeter incision. And with that incision, I don't really need a wound assisted implantation. The mouth of the cartridge goes into the anterior chamber, and you can have a much more controlled incision and with outstanding consistency. As far as the Vivinex toric today is available in a very robust platform, in the sense it's made up of absolutely glistening free, crystal clear, free hydrophobic acrylic material. It has a proprietary aspheric optic design, which I think will be dealt with by another speaker soon enough. And the most important aspect is the active ozonization on the posterior surface, because of which there is an inherent tendency to reduce posterior capsular opacification apart from the square edge posteriorly. Outstanding rotational stability, and the median rotation of these lenses has been said to be less than 1.1 degrees within 6 months of follow-up. That's something amazing. There has been, in a significant follow-up of 103 eyes, it has been shown that none of these lenses rotated beyond 5 degrees, and the average range of rotation is just about 1.21 degrees. And this is in comparison to the other usually used toric intraocular lenses, which are also excellent lenses. But the Vivinex, none of the eyes within 6 month follow-up rotated beyond 5 degrees. 4.8% in the case of Acrisoft toric, 7.5% in the case of Technes toric, and 13.9% in the case of Envista. Obviously, these are, if we can have a lens which is absolutely stable, that would be a good way to go. The video is my last slide, and this is just to show you the ease with which this lens can be implanted. And this is the preloaded injector in which this lens is dispensed, and that's the lens that is there. It goes in, you can see the mouth of the cartridge inside the anterior chamber through this 2.2 millimeter incision that I have, and it's an extremely controlled injection that you have. And the ozonization on the posterior surface, you can see the rough surface of the haptics over here, shown under reasonable magnification, because of which the contact with the capsule of fornice is quite significant. This is with the Varion overlay showing excellent centration of this lens on the table. I do believe the HOYA toric lens, which has been available to us, is a very significant addition to in our armamentarium to deal with cylinders during our cataract surgery. Thank you so much for your attention.
Thank you, Dr. Ramurthy, for the wonderful talk. I want to just take the quick opinion of the panelists. How many of you are using Vivinex toric on a regular basis? Starting from the right side, Rohit, Namrata.
Yeah, I have been using it quite consistently for the last maybe 8 months or so, and there's never been any PCO as has been shown because it is on the platform. Number one, and number two, the rotational stability I find.
It's not OPL. Please wait.
Is amazing.
Yeah, very good. Because the previous HOYA toric lenses I've used and it is awful. I'm talking about the non-Vivinex platform.
Yeah.
So I'm just wanting to ask Namrata Anaga whether the glazed haptics has made some changes in the not only in the negative dysphotopsia but also the stability of the rotational stability of the lens.
Completely agree with you. The glazed haptics
Mic on, correct.
the glazed part has really definitely improved the rotational stability. I mean, earlier also I think it was quite good.
Yeah.
But now there is a structural element added to it, you know, which has definitely, I didn't have PCO earlier also for that matter, but definitely I think rotational stability has improved with this.
Good. Anaga? Quick.
So specifically in high myopes or in a small pupil or in complicated cases, all the more it works really well, and it's so dependable and reproducible each time. So that's why it really makes a difference.
I think they got the best injector systems also, the HOYA. I think we are going to talk about it now, and Maipal is probably the best person to talk about the multi-set system, the preloaded IOL injector system of HOYA. Maipal, over to you.
Yeah. Thank you very much, Mohan. Can I have my slides, please? Slide. Okay, thank you. I'll be talking about the preloaded injector system, which is, I think, a part of the HOYA lenses that are being sold, and I think this is one of the factors that is actually making me use these lenses more than what it is. Now, whenever you are looking at preloaded intraocular lens injector systems, there are several desirable features that are there as compared to a manual loading. I still remember when we started with the foldable lenses, it was with the silicone lenses, and they would, if anything was wet, they would just jump out and go on the floor. So that from those days to something which is much more secure, that is something very, very important. Now, apart from the ease of insertion and the security, which I will be talking about, there is this obvious advantage that you have, that the risk of contamination goes down, because you don't have to take out a lens with a different instruments and put it at a separate place, etc., etc. And also there is the reduction in the risk of IOL damage, because there are not many instances with this particular injector system, which is a preloaded injector system, that we have got any breakages or damage of the optic or the haptic that is there. There is less reliance on the skill of the individual who is loading the lens, because the steps are pretty much clearly marked on the injector system, and this is what has to be done, is what it is. Apart from that, the efficiencies that you have in the OR, they increase, and the amount of time, if you have a busy OT, it has been shown that you may be saving up to about 30-40 minutes a particular day when you are getting the lens loaded, if you are doing it yourself, and you are obviously requiring fewer instruments to reprocess. Obviously, this is a disposable single injector system in which the lens comes. So the other important thing is that you don't need to have a separate inventory that you want, that with the injector system you have to keep separately, the lens you keep separately, etc. So that is the other advantage, and the predictability and the consistency of the IOL delivery will be there. So there's no question of a mismatch, because the lens and the injector come pre-labeled, that is there. Now, if you look at The other advantages which we'll be talking about is that it has both the options that you can push it or you can use as a screw motion. And apart from the lens advantages, which I think somebody might be talking about, toric, Ram has already talked about, that is the rotational stability. This lens is a glistening free lens and it has a proprietary aspheric. Now when you come to the injector system, the nozzle in a hydrophobic preloaded lens is the smallest. That means that it is the narrowest that you have. And there is the obvious, which has just been talked about, which is the active oxygen processing, and it is a screw preloaded, as you can see. And there are these two lenses that are available, that is the Nanex and the Vivinex. And the Nanex, because of the material that you are using, the micro incision can go as small as 1.8 millimeter. Now this, let us just see as to, this is just the lens, aspheric design, hydrophobic, modified C loop, 6 millimeter, 13 millimeter. This is the power, this is the A constant, 119.2, multi-cert preloaded, and the front injector tip is just 1.62 millimeters that is there. So the incision size can be as small as 1.8 millimeters. Now these are sub 2 millimeter lenses. There are more than 10 million units that have been implanted worldwide over 15 years, and the results are pretty good. The oxygen treatment, as has been pointed out by Dr. Ramamurthy, that helps in reducing the amount of posterior capsular opacification that is there. So this is how the injector system looks like. Looks pretty sleek, pretty futuristic, that is there. And there are the steps that we will just tell you. So wound that you have minimizes the wound, which is outer diameter has 1.62, so you can go through 1.8. Delivery is very consistent and very smooth, so it never, at least in my hands, I have never had it coming out with a jerk. So it's a very slow gradual release, and it's a 4-in-1 preloaded IOL system, which provides you the choice, as I said earlier, between a push and a screw type. So that is however you feel comfortable, whether you want to use just one hand or you want to two, so you can do the push or the screw type that is there, depending on the surgeon's preference. So now let us look at this is the single-handed, as you can see, which is the push, and this is the two-handed, which is the screw. So let us go through these two types which are there. You can see that this is the lens which is being pushed in for the implantation, and in this particular case you can see that you can actually use the screw motion. So these are the two different varieties. So one will be single-handed, the other you would possibly need to hold it with two hands to do that. Now when you look at it, there are, again, you have two options apart from the push and the screw. There are two options, whether you want to make the tunnel as a part of the injection system or you want to inject within the eye. That means that you can have these shields. So you can have these two shields. You can see this is the smaller one and this is the larger. So this is an insert shield. So you can see in the first it is delivery into the capsular bag, while here it is part of the incision tunnel. So that is what is important, that whatever way you want, you can really look at it. And this is just to show you the comparison of the various sizes of the nozzle that you have, and the smallest nozzle that is available in an open loop preloaded hydrophobic lens, as has been said by me earlier, which is 1.62 millimeters outer diameter. That is the injector tip of the Nanex. The Vivinex needs about 2.2, but this is about 1.8 that you can go through. So sub 2 millimeters, 51% reduction in the wound stretch that has been shown, because if you want to do a 2 millimeter incision, and final incision size 28% reduction in the wound stretch that you have. So this is the comparison of the forces that are required between various CT Espina, Crystalens, Ray 1. So you can clearly see that the Nanex scores over the other ones as regards the ease with which you can inject. So there is no, the other thing that I said, no cracks significantly that have been loaded at all, no damage. And there is no leading or trailing haptic tucking failure that has been reported in a particular study in 630 attempts. No broken injector tips after IOL release has been reported again in these 633 eyes. Now, I'll just show you the process, which is very simple. So you can see this is what it is. The first thing is there is a hole here, which is the infusion port through which you put viscoelastic. And once you put viscoelastic, the next step is to, there is this button or a knob here, you just pick it out. And then there is a slider with which you push in the slider. And then after that, so viscoelastic, taking out the release tabs that is there, then you have the slider pushing it in, and then you take out the whole injector system. This is how it comes. So you see, obviously there is no touch and no contamination. And then you can have the plunger going in, and you should verify the position within the injector system before you actually go into the eye. So these are two animations, and one we have. So this is by the company that they are doing. This is the Nanex Multicert, as they call it. And this is just an instructional video which is providing an illustration of to how it goes. So the model of the lens, as you know, optic diameter 613 overall optic design. This is the Multicert, as I told you, injector tip insert. As you, there is a volume here. Can you just give a slight volume? This is the rod. This is the slider. So this is how it comes. Open the seal of the sterilization pouch which is there. Pull the injector out of the pouch by holding at the tab. This is the place where you put the viscoelastic. You don't need to put sodium hyaluronate. You can do it as well with the methyl cellulose. You can fill up to the area that is shown on the dotted line. So you can see this is the viscoelastic that is coming here and going back. Now this is the release tab. That means that you have to just pull it out. It's fairly simple. You can see this is the release tab, and then you slide in the injector. This is the slider that goes in without any applying any upward or downward. So you're not wanting to pull it out just now, but you're just wanting to push the slider. And once you have this, then you verify that things are all right, and you remove the injector system from the case. And once you have removed that, then you gently advance the plungers forward. You can see this is rotating round as you are injecting it in, and the advanced plunger should require not more than 4-5 seconds, and you can see easily paying attention as to verifying the position of the...
Yeah.
Is that for me?
Yeah.
Okay.
For you only.
Okay, so that is
we have 4 more speakers to go.
Sorry?
We have 4 more speakers to go, I said.
Okay. So that is the injector system which is going in, and there you can see it going inside as the stabilization you can have. So this is just to give you the actual injection. You can see it takes as little time as is shown here. It is not edited from that perspective. You are just taking it. This is the lens which is there, and you are picking it out. This was a pace in which we had used iris hooks. As you can see, you can easily see the lens. You can see the trailing and the leading haptic which is there. And you can see that we go and are able to insert it within the bag. Look at the slow unfolding. That is what I wanted to show you. It's actually a very gentle, and there has never been any problem as regards the rip of the posterior capsule which is there. So the Vivinex, etc., Nanex, the injector systems are pretty good, and they offer a clarity of vision. This is designed for unmatched control at your fingertips, highest diopter powers that are available. So to sum up, both these lenses, including the toric version, the spherical and the toric, these are preloaded IOLs and are much easier to prepare and load with increasing safety by reducing the risk of contamination and infection. Multicert injector gives the flexibility of both the push and the screw type, and HOYA's proprietary active oxygen processing treatment gives significantly lesser PCO rates, and most IOL loading complications are circumvented by this preloaded IOL system. Thank you very much for your kind attention. Thank you.
Thank you, Dr. Mahipal, for that very comprehensive coverage. Right now, we have Dr. Suhas Haldipurkar talking to us about another important consideration, incisions during cataract surgery.
So thank you, Ramu.
You can make it 8 minutes, Suhas will be fine. 8 minutes. 6 minutes. 6 minutes. Yeah.
Thank you so much.
Maybe I'll give you 1 minute more for you, 7 minutes.
Thank you so much. And I also would like to thank HOYA for this opportunity to talk. I'm going to talk about incision considerations during cataract surgery. Now, incision positioning impacts the corneal shape and induce astigmatism. See, there are three types of incision that we can make. One is a scleral tunnel. The pros are it has a better stability and reduced infection risk. Cons are takes extra step to open conjunctiva, access to capsular bag, little tricky. If you go to limbal, there's stable wound, improved access to capsular bag in comparison to scleral tunnel, but associated with more bleeding and foreign body sensation. The clear corneal incisions, quick job, easier IOL implantation, but induced astigmatism is there but can be minimized by appropriate modification. Now, if you talk to speak about incision architectural considerations, there can be multiplanar incisions incorporating both vertical and horizontal element, or are thought to be better to resist leakage, and a square incision is stronger than rectangular ones. Now, this is a video film of the surgery done with 1.8 incision. This is done with 1.8 a special needle from Oertli, and this is a keratome which is 1.8, no, it's 1.9. The surgery is usual. This is that tiny tip that you use. Then I use a caliper and try and check what has been the size, because the phaco tends to stretch the wound. The 2.1 doesn't go, but 2, even with 2, it's hard. So the incision has not stretched much. Then I'm using the Nenex to go within, especially when you have a small tunnel. You cannot do a wound assisted. For a safer delivery, you try to go in, and that's when the cartridge tends to stretch the wound. Now here the Nenex has gone into the wound. To start with, it was 2 millimeter. At the end of the surgery, I check again, and with 2.1, it's snugly going in. So what it goes to say, that what is promised by this Nenex is reproducible. When it comes to dimension of incision, there can be a good form and a poor form. The good form will have radial entry, straight in, straight out, and it has to be a symmetrical incision where equal thickness of roof and the floor. Now, impact of IOL implantation on the incision would be cornea's capacity for stretching and deformation is limited, and hence can be damaged by excessive stretching during cataract surgery. This damage depends on several factors. It can be because of injector cartridge size and design, IOL insertion technique, speed of IOL insertion, and IOL power and thickness. The advantages of smaller incision, as we all know, there's an improved refractive outcome, faster patient recovery, less post-op complication, and lesser chances of infection. Now, this is the most important slide of my presentation, in which they have compared the conventionally available preloaded or the cartridges that we use, of which the Nenex Multicert is said to have the smallest available nozzle size, that is 1.62 millimeter outer diameter. So when you have to push an outer diameter of 1.62, even if it can go through sub 2 or sub 2.2, we have still achieved a lot, because most of the phaco machines that we have, we use 2.2. But we have done a study in the past, through 2.2, when you push in the conventional preloaded cartridges, the wound gets stretched to almost 2.4 or 2.5, But here, if you have a availability of going through 1.8, and if you want to contain your wound to 2, it is made possible by Nenex, where as you saw just now, with a size of 2, my lens was implanted. So that's an important, a step above most of the other available. So with available technology to perform phaco through 1.8, Nenex Multicert fills the unmet need of an injector system that can deliver through 2 without stretching it significantly. And this data which was showed before is very important. In a sense, there is almost 51% reduction in the stretch in the final wound. And with this, I would like to end my talk. Thank you so much.
Thank you, sir. Thank you very much for the beautiful presentation. I think what is very important, because we all want to reduce the size of the incision. We are reducing the size of the nozzle for the injection. But what is more important is there an IOL which goes through 1.6 millimeters safely? What we have seen with the other IOLs, you get many times, you tend to get scratches on the IOL. Your IOL will disfigure, and many times the IOL may tear also. So I have not seen any case with Nenex or Vivinex injecting through 1.8 or sub 2 millimeter. I don't see any changes on the IOL surface. It means the IOL is designed in a way to be injected through 1.6 or 1.8 millimeter. So this is the biggest point with this IOL, I think. Dr. Ramamurthy.
I absolutely agree. I mean, I think that's a distinct advantage. Next, we have Dr. A.K. Jain, Professor A.K. Jain, who is going to be talking to us about optics, spherical aberration, and coma.
Thank you, Dr. Ramamurthy, and at the outset, I'd like to thank HOYA people for giving me this opportunity. So coming to the optics of this Vivinex platforms, I will be mainly discussing how this lens improves the quality of vision in comparison to other lenses, and the secret lies in the optics of the Vivinex platform. No financial interest. What is Vivinex platform? As we will discussing in the part of this presentation, it has a proprietary aspheric optical design and a new glistening-free acrylic material, new delivery system you have already heard about, a very stable toric platform, and it also prevents the PCO. Recent studies have shown that it has the minimal PCO rates. So, as we all know, eye has a higher order aberrations and the lower order aberration. Higher order aberrations account for 80 to 90% of the optical defects, but the higher order aberrations, most common ones are the coma and spherical aberration. They account for 10 to 20% of optical defects in the optical systems of the eye, and they account for 10 to 20%. As we all know, the normal human eye is not perfectly aligned. All the optical, the cornea, the crystalline lens, and fovea, they are not aligned on an optical axis. There is a tilt and misalignment. These both things produces astigmatism, coma, and other higher order aberration. And the impact of coma and spherical aberration on image quality is quite significant, as is available from change in point spread function and retinal images because of effect of coma and spherical aberration. And there is a naturally occurring ocular coma in the eye, and it has been shown to increase with age. Even the cortical cataracts also have been shown to increase the coma in human eye. And coma is naturally induced by the shape of the cornea, and this can manifest both as vertical and horizontal coma. And it has been shown that the internal optics of the eye, in particular the crystalline lens, it compensates for the corneal induced coma. And coma can increase with age, possibly due to the changing properties of the natural crystalline lens, and larger pupil and dim light condition or dilatation of pupil has been linked with increased coma. And decentration and tilt of the crystalline lens has also been linked with increased coma. As we all know, the cornea has a positive spherical aberration and the normal young lens has a negative spherical aberration. As the age increases, the negative spherical aberration of the lens decreases, but the corneal aberration remains same throughout the life. So in older age, we are left with increased coma aberration in the spherical aberration in the eye, and cataract surgery is an opportunity to manage spherical aberration. As we all know, human cornea has an average slightly positive spherical aberration of plus 2.27 micron, and aspherical IOLs are designed to improve the quality of vision by compensating for the natural positive spherical aberration of human cornea. However, the effects of coma on image quality is not routinely considered. This is two eye of the same patient. In one eye there is a normal lens without asphericity. In other eye there is a lens with asphericity, and you can see the point spread function and the stare ratio, which is much better in the other eye. So patient has a 6/6 unaided vision in this eye. So the sources of ocular coma, once we do a cataract surgery, the sources of ocular coma remains because cataract surgery, the naturally induced corneal coma is unchanged by the cataract surgery, as the difference between the visual and optical axis is unchanged, and the correlation between IOL placement of the visual axis and coma is also significant, and induced coma has been shown to be higher in patients implanted with aspheric IOLs than with spherical IOL. This is known fact. More is the asphericity of the IOL, more decentration will lead to more coma aberration. And unlike spherical aberration, coma has not historically been considered at the time of cataract surgery. And spherical aberration correction may come at a cost if we consider the impact of coma. And coma can increase when compensating effect of natural crystalline lens is removed after the cataract surgery, and relative to spherical design, lenses with negative spherical aberration are associated with image quality having higher sensitivity to being positioned off the visual axis, as is evident from this study, the picture from this study. The advantage of aspheric IOL design could be limited or cancelled or become disadvantage when the IOL decenters as compared to a aspheric lens. And choosing an IOL with optics that considers spherical aberration and coma is important. This is the only lens which takes into account the coma aberration because of this unique optic design. It has a negative spherical aberration of 0.18 micron of spherical aberration, and partial correction of average spherical aberration of human cornea maintains the patient's depth of field. But how tolerant are the optics to sources of coma in the eye? So let us see that coma occurs because the visual axis and the pupillary axis are not the same in human eye. There is an angle between the visual axis and the geometric axis which leads to these aberrations, and studies have shown that the mean position of visual axis of an IOL following cataract surgery is around 0.4 millimeter plus minus 0.2 millimeter standard deviation. And the proprietary aspheric design of this lens is there is a small area of 1.2 millimeter positive asphericity in the center, followed by a 1.2 millimeter annular zone of negative asphericity, and then again a zone of strong negative asphericity. What this does is the two distinct aspherical elements in the center of the IOL, they work in harmony. The first element, the slightly positive 1.2 millimeter optical zone, induces a positive coma using a convex meniscus structure, and the second element of annulus of 1.2 millimeter around this central zone induces an equal negative coma through a concave meniscus structure. So this is an experiment study published in the literature which has compared 3 lenses, HOYA Vivinex, the Acrisov as well as Technes, and they have shown that the lateral decentration resulted in decreased retinal image quality of this HOYA Vivinex lens, and it was most immune designed to optical degradation caused by decentration. As you can see, it is evident in these figures, and it was demonstrated that Vivinex placement has greater resistance to coma, and the rate of increase of astigmatism, increase in coma at 0.4 millimeter, as well as decrease in visual sterile ratio at 0.7 millimeter. This was the best with Vivinex as compared to other 2 platforms. And again, this is evident from this bar diagram that reduced coma caused by off-axis alignment.
Arun, can you just wind up?
Yeah, just I am concluding. And the visual sterile ratio is best maintained by this lens. This
Arun, can you just wind up?
Yeah, last 2 slides.
Yeah, okay.
Okay.
Thank you.
This is the study which I have done, and this is the only clinical study which studies about this sterile ratio and coma aberration and other aberration induced by this eye, and this has already been accepted in JCRS. And in this study we noted the decentration of the lens in relation to visual axis and geometric axis, and showed that Vivinex ICED had a better sterile ratio compared to the other platform. And what this study concluded was aspheric IOL induced higher order aberration, especially coma, when decentered. And the effect of IOL decentration is sensitive to IOL design. In vivo, the geometric axis and visual axis do not coincide. The result may vary from simulated trial, the experimental trial, and decentration of the lens is best measured with respect to visual axis. And in eye with large angle alpha, the aspheric balance curve design performs better by inducing higher order aberration, maintaining a better sterile ratio. And this is to conclude. So this platform has a unique negative asphericity and less sensitive to alignment problems, and combines the benefit of traditional negative aspheric as well as with that of additional benefit of neutral aspheric and visual axis compensation mechanism beneficial, since visual axis doesn't typically coincide with IOL optical center, and the patented proprietary aspheric optic design reduces the coma that is typically induced by decentration or tilt of traditional negative lenses.
Thank you,
Thank
Arun.
you so much.
Thank you, very nice presentation. And since you're running short of time, we'll have a discussion later if we have time. Over to Rajesh Sinha is going to talk about PCO, whether the active oxygen processing, does it make a difference?
Thank you. I would like to thank HOYA for having me here in this meeting and in this session. And I'll be talking about what are the strategies that we keep doing for managing posterior capsular opacification, which is something which we have been fighting for years, for ages, that we implant an intraocular lens, and many times we do have PCO, and that jeopardizes the success of the whole story. And the major reason why there is PCO is because of the fact that there is LEC migration from the equator towards the center, and that creates the generation of pearl type of LECs, pearl type of PCO, or you can have a fibrotic type. And of course, we have been treating it by use of Nd:YAG laser, and if it's a thick membrane, we do surgical membranectomy. But then there are certain issues related to these lasers, like you can cause pitting of the IOL, there can be IOP rise. If you do a membranectomy, there's risk of retinal detachment. So all these things are there, and the idea is to prevent PCO, not to have it and not to treat it. So for various strategies have been employed for treating PCO. You name one, you can name 10 of or 15 of those. Employing a very good surgical technique by doing a good hydro procedure, etc., and polishing of capsule, and all these things have been done. But the main thrust is on IOL design, and currently as far as the design is concerned, it is the square edge optic design and square edge haptic design that is a very important factor. What it does, it causes a bend in the posterior capsule, and that prevents the LEC migration towards the center. So this is how it does, and there are various studies that have shown that square edge design helps. There are certain drugs that have been used to prevent PCO. There are certain IOL materials and surface modifications, all have been done. Now currently, oxygen processing of the posterior surface is being tried, and what it does is that the IOL posterior surface is subjected to ozonation. A singlet oxygen is created. It creates a cleavage into the molecular chain, and that increases the adhesiveness of the posterior surface of the intraocular lens. And along with the square edge, if you have a good adhesiveness of the posterior capsular surface with the capsule, then the chance of LEC migration towards the center is minimized, and this is what we get to see in the current generation Vivinex IOLs. So this is about the Vivinex IOL. It also has a textured rough haptic. So the advantage is that when you implant the IOL, the two haptics don't get attached to each other, don't stick to each other. And the other advantage is that the adhesiveness with the capsule is better. So rotation in a toric implant will be minimum, and is because of this rough textured haptic, better capsular adhesion, square edge haptic as well, and the surface of the square edge of the optic is not polished. It is also rough. And because of this, the risk of dysphotopsia is also less with these Vivinex design. So I would like to, highlight here is that posterior capsular opacification is something which jeopardizes all the hard work that a cataract surgeon does. And then you have to create an opening in the posterior capsule which can have its own complications. So the best thing is to prevent a PCO. Various methods have been employed. All the methods have been aiming to prevent the migration of the LECs, lens epithelial cells, from equator to the center. The square edge design of the optic creates a bend, and that prevents the LEC migration. The posterior surface of this Vivinex IOL is ozonated, so the molecular chain is cleaved, which creates adhesiveness of the posterior surface of the IOL with the capsule. So a bend and the adhesiveness combined together prevents the LEC to migrate from the periphery to the center quite significantly, reducing the risk of posterior capsular opacification. And so far, as far as my experience is concerned, I have found it absolutely what it claims. So thank you very much for your patient listening, and any query, any question if you want to have.
Thank you, Rajesh, for the wonderful presentation, and all your points have been well taken, and I think it's important to prevent the PCO. I think we have overall a very good system now, a good preloaded system, and the good injector, and a good biocompatibility of the lens. The PCO is less, rotational stability is very good. So quick 1 or 2 points from this side. We have a couple of minutes. Anurag, Nitin.
Yeah, the preloaded system, particularly of
I just want you to highlight what are the main features, highlights you have seen in your practice.
That's what I'm saying. Yeah. What I've seen is it doesn't even need a push. It's actually a push type injector, but it's a kiss type injector. So
kiss type.
Needs to kiss the plunger, and there's the force transmission onto the plunger tip is so uniform that it doesn't give way, it doesn't stuck. So rest is up to the audience to see it, to use it, to believe it. It's that kind. So one has to use at least one unit of this to believe the beauty that lies encompassed.
Yeah. The new multi-cert is a wonderful injector, and I think is the best in the market currently. And otherwise lenses are good with all the good features that already speakers have highlighted. But I think the injector is the best in the market.
I think the predictability is all what it stands for. So whether it's a low diopter or a high diopter lens, it always unfolds in the same way. So I think that is the most important point for me. You never have surprises. You never have that optic haptic kissing, so you don't end up wasting time there. So low PCO rate and that wonderful predictability and, the respect to the incision I think all these key points make this system as a wonderful delivery system and no touch technique. It's fast surgeons on the dais. I think everybody does a huge volume and it takes off the OR time actually and no contamination. So ends cutting off the incidence of end off and contamination. So I think overall it's a wonderful delivery system and probably we have to see more platform. They promise to give us the EDOF, the multifocal and the trifocal on this platform. So I think more innovations to come and thank you so very much.
Yeah, just last
Final,
thing, yes. So it's a complete all-rounder with the best haptic technology, best optic technology, so you get clarity with stability. So I think we can't ask for more.
I think that's the message. It's a complete all-rounder, probably the best all-rounder as of now. Thank you very much.
Thank you, everyone.
Thanks, Hoya, for the wonderful session.
So thanks, Hoya, for giving us this session. Thank you very much.